Today's hearing is an opportunity to examine the 340B drug pricing program. I will start by saying that this hearing is a personal one for me. I made a promise to my friend and fellow Virginia member, Don McEachin, that I would do a 340B hearing shortly before he passed away. He called me regarding a 340B news story relating to his district before the last election took place and mere weeks before his unexpected death. And he said, if you're E&C chair of oversight and investigations, I need your help on 340B. I told him we would work together. So I am glad that I can fulfill part of that promise. The 340B program was established by Congress to allow certain covered entities that provide care to a large number of underserved patients to purchase drugs at significant discounts from manufacturers. In theory, the savings are meant to be passed along to patients and to be reinvested in the community to help provide additional care or resources. But it is not mandated to disclose where these dollars actually go and how they are made from, and how much they are made from the program, or how much is made from the program. Thus, we in Congress, with our oversight authority, are mostly blind as to what happens with these dollars. When the Affordable Care Act was signed into law in 2010, the program rapidly expanded by allowing more entities to receive the discounted 340B price for drugs. Because of that and maybe some accounting issues, the number of covered entities participating in the 340B program has increased from 8,000 in 2000 to more than 50,000 in 2020. Today, the 340B program accounts for almost $54 billion in annual discounted sales, making it the second largest federal prescription drug program. There are many hospitals, including those in my district, who I believe are appropriately using 340B dollars in order to keep their doors open, and they heavily rely on this program. I'm a supporter of the overall concepts of the 340B program. Yet we see reports about entities taking advantage of the system, and that is what caused my friend Don McEachin to give me a call. The New York Times reported on how Bon Secours Hospital System apparently used the Richmond Community Hospital in Virginia, which serves predominantly poor patients in what was then Don McEachin's district, to expand its use of 340B at the expense of the Richmond Community Hospital and patients in that community. The New York Times asserted that over the years, services at this Richmond Community Hospital were slashed and departments closed, while Bon Secours used the hospital as a piggy bank and transferred millions out of Richmond to other hospitals within the multi-state system. This is a reverse Robin Hood scheme: steal from the poor to help the rich. One specific example in this report was Bon Secours using the Richmond Community Hospital to purchase a cancer drug for more than $3,000 and then turning around and selling that same drug that they had bought under 340B for more than $25,000 to a private insurer. This is $22,000 in profit from one single vial for one patient. When reports like the Bon Secours situation occur, it is our job to step in and provide oversight into the program. The 340B program is a lifeline for many hospitals, health clinics, community health centers, and many other healthcare facilities. My district has more than 50 community health centers, and 340B serves as a critical tool to help keep their doors open and to provide additional services for my constituents. When I visit these centers and hospitals in the district, they are very open with me about where their 340B dollars go and what they use it for. That's because my district is economically stressed, and healthcare providers rely on these dollars directly to serve their patients. I believe creating more transparency in the program so we can see where the dollars are flowing and ensuring the program is not being taken advantage of is the first step. This will allow Congress to understand the full picture and ensure the patients are the ones receiving the benefits of this program. The patient is the one who must come first in this, and they should not be caught in the crosshairs of any of the issues we will hear about today. That's the pledge I made to my friend Don McEachin, that we would work to make this program better. There was never an intent to get rid of the program. There was never an intent to cripple the program. So what we're trying to do today is to get information on how we can make the program serve what was the intent of the program: the economically stressed areas and the economically stressed patients. With that, I yield back.